All right, my dears, I say we get going. So for those of you that don't know, I'm Emily Weiler. I'm the program coordinator for the Montana Public Health Training Center here housed at the University of Montana. And we're excited for our program planning and evaluation training today with the awesome Kimber McKay.
My name's Kimber McKay, and I'm a faculty member here in the School of Public and Community Health Sciences here at the University of Montana. I've been teaching here for 21 years, and my original start was in the field of anthropology and doing medical anthropology, which I didn't initially start out doing, but I was researching for my dissertation a very unusual marriage form called polyandry, where women have more than one husband at the same time. And so I was studying that among ethnic Tibetan people in the Himalayas. And here's a picture of me spending some time with some people, a couple of villages down the trail from where I lived during my dissertation research. And so it gives you a sense of the topography and what the houses look like from the exterior. And what happened when I was living there was just a realization that these are people whose lives are very much affected by program planners and program implementers. They are the targets of a huge amount of interest and assistance, quotation marks, in the international development community. Because this district of Nepal, where I'm sitting here in this picture, is quite remote. They don't have electricity, or they didn't at that time. And although you can see in the background in this picture, some electricity poles are going in at the time that the picture was taken from a Pico hydroelectric installation. And they had very serious health challenges there that were a result of a lot of different cultural and socioeconomic and education and health infrastructure reasons. And what I realized was that I didn't really have that much interest in being a part of the international development community at that time. But I realized if you can't influence that industry with some of the on the ground know-how that I was able to bring a little bit of a perspective of with my local counterparts, then the industry would continue sort of bumbling along trying to build programs and implement them without sufficient feedback or intel really from the ground about social hierarchies and the social determinants of health in this particular setting, and all kinds of other things that were affecting the way that I could see, because I was living in the villages, the ability of these programs to reach the ends that they wanted to reach. And I also have spent a lot of time in East Africa, along with some of the people on this call whose faces I recognize or names I recognize, also have worked in that setting. Facing similar challenges in those communities there, where these communities are, like a lot of rural and frontier communities around our state of Montana or our region in the Rocky Mountain West, you know, they're the subjects of different kinds of programs and initiatives that are better and less well planned. And so that really kind of it spurred me to join the international development sector, and specifically the global health part of it, and develop my own knowledge of and expertise in program planning and program evaluation. And in more recent years, that skill set has transferred over to a lot of the work that I'm doing on the ground here in Montana, particularly in maternal and child health initiatives, and working with different people around the state and different entities, also in that program planning and evaluation capacity. So I really love program planning and I really love program evaluation. I love it because I think it's absolutely critical for good work. And I find it very comforting because it's fairly recipe book, like it's fairly determined the path that you should strike out upon to get the work of program planning and program evaluation done. This is a well understood, in my estimation, body of work. And it's really only a matter of making sure that you're working the checklist and thinking thoroughly and completely about all of the pieces of the checklist, all of which are available on your program planning and evaluation agenda for today. But also bringing your own innovativeness and creative ideas to the table, because there are lots of places along the way where it's not recipe driven, where you have opportunities to think outside of the box to make programs better. So I love that too. Okay. One of the things that I've done quite a bit of thinking about and working on in different teams that I've worked with is the absolutely critical part of this or stage in program planning that has to do with identifying stakeholders. And if you don't spend the amount of time that you need to spend really critically and creatively thinking about who the stakeholders are in the community that you are hoping to help, you can pretty much guarantee that your program will not reach the ultimate goals that it could. And this is just a picture of me talking with some nursing staff about their views and how to integrate their views and experience working in a NICU setting. This is in a hospital in Uganda, into some of the program planning exercises that they were working on. And one of the things that we see a lot in program planning is that programs are planned in offices or even cities far away from where they're executed. And that, generally speaking, doesn't tend to be a great setup. And to circle back where I started, like when I was living in the villages in Nepal, I could really see the failures of programs that were the result of not getting that stakeholder buy-in. And so the first breakout room discussion that we're going to have this morning really does focus on this question of stakeholders. Before we get there, though, we have some foundational work to do or some topics to cover. A lot of people that come to our webinars here in the Public Health Training Center are already working in the field of public health, but don't necessarily have any formal background or training in public health. And so I always like to kind of start out with an overview of what public health even is. Like frequently, and Emily can attest to this as well, I'm sure, we do have people in our webinars who say, I actually don't know what is included in public health. Of course, also we have many people who have advanced degrees in public health. So just to make sure we even up the playing field, I'm just going to do a couple of slides of a refresher. The main areas that are considered to be like the core for public health work are on the slide here. So that includes behavioral science and health education, biostatistics, environmental health, epidemiology, and health services administration. So those are kind of the 5 core areas that we train students in our Masters in Public Health, and also are touched upon in our different certificate programs, and also in our brand new Bachelor of Science degree in Public Health. So this is really the core right here. Over time, what happens in our field of public health is that you have different overarching rubrics that guide the work that we do. And there are lots of different examples of this. One I think that is relevant right now is Public Health 3.0. And that's a phase that the phase that we're in right now. We can compare that to where we started. So public health as a formal sort of recognized field has its origins in the 1800s. And, in that early part of the kind of emergence of the discipline in what is on this chart referred to as Public Health 1.0, we saw a tremendous growth of knowledge and tools, both for medicine as it became formalized and the practice of medicine on the one side, and then public health on the other. So where public health is generally thought to be a preventive approach, and medicine is, more frequently thought of as being a more of a curative approach. During that first phase, obviously, there was uneven access to care and public health in communities, and in this instance, to primarily Western Europe and other parts of the world that we would now consider to be the developed nations. Then, as time goes on, we've phased into Public Health 2.0. And there we started to, in that phase, see more systematic development of the field and government agencies that govern it, at least in our country. And during that Public Health 2.0 phase, it's understood that focus was limited to traditional public health agency-based programs and public health initiatives that were, generally speaking, more targeted, more disease focused, and the like. Now, if you compare that with Public Health 3.0, the phase that we are considered to be in now, you see a much more holistic and multidisciplinary way of doing things coming in. And so the engagement of multiple sectors and partners across the community to generate a collective impact, and also a recognition of the social determinants of health and programs that focus on improving the social determinants of health. And now, I think now most people consider a social determinants of health approach to be fairly commonplace and mainstream. And that from my perspective, as somebody who came out of the social and behavioral sciences, but particularly the social sciences, really, focusing on culture and cultural differences and social and socioeconomic differences between and within communities and how those affect health. I'm thrilled that the social determinants of health approach has become so mainstream. We also teach a lot of different webinars in our Public Health Training Center, and I actually offer one just about the social determinants, which I taught actually a few weeks ago, and I think some people on this call were in that. I think Trina might have been in that one, but in any case, so that's kind of how the field has, like broad overview, how the field has evolved. I'm going to share a different screen, if you'll just bear with me. I need to take you over to this one here. Now, what do you see, Emily? Do you see my slide or do you see a CDC?
I see CDC.
Oh, great. Okay, so a couple of resources that I wanted to share with you. One is Healthy People 2020 or 2030. Oh, sorry, I can't get all my tabs open because they're hidden behind the Zoom thing. Healthy People 2030, in addition to this thinking about public health phases 1.0 to 3.0, Healthy People 2030 is the US Department of Health and Human Services overarching sort of rubric or guiding principles that also govern our work in the public health field. And there are lots of things on this website that I really love, and some of which I reviewed recently having to do with social determinants of health in that webinar. But what I wanted to highlight for today was how the Healthy People 2030 website, which is very recently updated from the Healthy People 2020 website, has a lot of richness in terms of tools that can assist and guide our work. And one of the things that I really love the most in sites like this is how concretely they help us identify things that do part of the job of program planning and evaluation for us. For instance, in choosing program objectives, for instance, in terms of choosing program evaluation metrics or indicators. So here on this objectives and data tab, we have the opportunity to browse objectives having to do with different kinds of health challenges, but also what are the leading health indicators per health challenge, and what are the best health and well-being measures or metrics. So I wanted to bring this to your attention because I think it's so valuable in the work that we do, because it helps. We don't have to reinvent the wheel here. Like, a lot of this is already, the evidence base is here, and the choices of metrics becomes easy because you don't have to think of or invent the metric yourself. It's already out there, and it's out there because it has an evidence base behind it. So I love that. The other thing I wanted to bring your attention to, gosh, why can't I see these tabs, is, here we are, the CDC's Program Performance and Evaluation Office also has a lot of richness on its website, having to do with, all kinds of interesting things relating to program planning and program evaluation. And so I just wanted to bring your attention to this website as well, to let you know that when you go home to your office or when you finish the webinar, there are lots of resources out there that are quite readily available, and I think, extremely valuable. I'm going to pop over now to back over to my slides. If you, okay, so do you see what do you see, Emily? The right thing? Okay, good.
Yes.
Thanks. Okay, so another kind of foundational thing that I like to do in these webinars is just acknowledge the fact that in our context in Montana and our rural and frontier communities here, we have specific issues that pertain to working in this and living in this kind of setting. And these are kind of these are bulleted on this slide. So for instance, we do have a disproportionate burden of chronic disease relative to the general public in our country, restricted access to healthcare, quality healthcare, insufficient or lack of health insurance coverage, geographic isolation, lack of transport, and a poor infrastructure, generally speaking. We also see other things that makes our communities stand out somewhat on the national landscape, and those are on the right here. So low, on average, educational attainment, low health literacy. We have higher rates of poverty and unemployment in our rural and frontier communities, smaller healthcare workforce and lack of specialty care, and other things that are more software or soft in nature, like limited available bilingual providers and interpreter services, and then cultural or social differences, stigma, and norms. And it's funny, as a social scientist and cultural anthropologist by my first training, that I always see these bullet points come last on a list, as if these soft things are somehow less important. I would say they're probably equally important to some of the other things on the list, but they're a little bit harder to, I think, wrap your head around and measure and so forth. And so people generally leave them till last. Now, if we think about what program planning does, it does accomplish a number of very important things. For starters, it helps us focus on what our priorities are. And they allow us to link the activities that we engage in with our office or team's strategic plan. They also allow us to formalize our efforts, in the sense that they are our efforts and activities on a daily, weekly, and monthly basis are linked back to a codified or kind of like accepted or mutually agreed upon plan that we've developed with our stakeholders. Also, plans help us set expectations and timelines and define roles and responsibilities of different team members. And then, of course, also they allow us to measure impact and validation of our programs. And last, and certainly not least, they help us provide continuity through change. And change is, of course, inevitable, and it seems like change is very frequent in health departments around our state, because a lot of the people that work in them find themselves chasing after the latest RFP, the latest grant opportunity, and so forth. And so one of the things that I've observed is that there is a huge amount of change in program initiatives and also, unfortunately, in personnel and personnel turnover. What a plan does is give some sense of continuity, because like I said before, it's kind of a codified, like on paper, mutually agreed with stakeholders who tend to be those in the community who are there year in and year out. And so it gives, say, new people who come into the office or new staff members that you're inducting a place to start. And what I love to do in writing program plans is develop preambles that can be, that are the same, no matter what plan we're looking at. There's a section of it that remains roughly the same from one to the next, and that is the piece that provides the continuity. And how you do that in any given office is really unique to your setting, but is something that I think is really worth thinking about. In terms of using evidence-based programs, like I was mentioning before, are available to us on the CDC website, and also through Healthy People 2030. I was saying in my webinar on social determinants of health a couple of weeks ago that Healthy People 2020, I actually like a little bit better than Healthy People 2030. And you can still find it on the internet because it has more studies and evidence base. I think they're still building that Healthy People 2030 site. So, but toggling between the two of them does get you to a fairly substantial evidence base on lots of different health challenges, or lots of different either programs or studies of programs that provide an evidence base for taking a social determinants of health approach as one example. But there are other approaches that have an evidence base substantiated on the websites as well. So these, so using evidence-based programs helps us do a couple of things. One is to help us identify areas of need and interest. This is especially helpful for people who are relatively new to their field. You know, I've talked to a lot of people in health departments in our state where they were at the bedside like last month, and now they're directing their program, and they may not know, like, what are, across this country, what are the main things that health departments are working on. Also, this evidence base gives us other tools, like it helps us identify the policy environment that's relevant, or helps us think more creatively maybe about what environmental supports are in our community that we didn't realize, or health benefit designs. Evidence-based programs also supports outcomes evaluations, which are the second half of our time together this morning, all about evaluation. And they can also help align resources and infrastructure just by virtue of benefiting from how other people have done this, and that's established in the evidence base that's published. So I always say that it's good to start out with a mission statement that is a solid one and really only takes 2 or 3 sentences. So if you're getting ready to start a program planning process, one of the best things to do is to start out with your team, or maybe with yourself if you're alone in your office, by just coming up with like an elevator speech, you know, what you could say in between, you know, floor 1 and floor 5 in an elevator if somebody asked you what your program was about. So 2 or 3 sentences that really adequately and precisely encapsulate what it is that the thing is about. And if you can't do that, it means that you might need to go back to the beginning and interrogate what was your idea in the first place, and why do you think your program's elements are going to have the outcome that you have intended. So in order to get toward building a mission statement, you have to ask some of the some of the right questions. And so, for instance, you probably should start with thinking about who you're targeting and be specific about that. If you're too general, you can introduce measurement problems, and I'll discuss later in the morning today what that can look like. You want to identify what you want them to do. Like, again, precision, the program components or activities. Again, precision is the key. You want to know how much you want a particular behavior to change, like a particular health behavior. Say, for instance, maybe your program is focused at obesity, and so you want to increase physical activity. You know, a good question to ask yourself is, you want to increase it by how much? And there are some ways to answer that question, like you want to go from, you know, X percent to Y percent, or you want to move the dial from 10 people doing a certain thing to in a group to 20 people doing a certain thing in a group, or what have you. Or you might want to say you want to have at least 30 people doing something, or you want to have no more than 10% of people affected by something, etc. So the more precision, the better. And then last but not least, you want to think about when you want to see the behavior change happen. So make the timeline specific and bounded, but also reasonable. So don't aim for change that is impossible to get in the period that you've defined. And generally speaking, the more modest, the better here, because change takes a long time. A little later in our time together, I'll be drilling down in much more precision and specificity into how you think about some of these questions, but this is just a little bit of a broad overview. Okay, so question here, what's wrong with this objective statement right here? So the statement is, our objective is to increase participation in the health assessment. Does anybody want to chime in about problems they see with this statement?
There's no baseline, so increase from what to what?
Yeah, absolutely. What else? Anybody? I'll help along. So in addition, was it Silvana that chimed in? Did I say it right?
Yep, that's right.
There's also Dawn in the chat box says no specifics about how much or when.
Perfect. Yes. Thanks, Dawn. Absolutely. So we don't have information about a bunch of different things, like who or what, how much, by when, better, would be something along the lines of residents of X neighborhood. The what is there still, how much, from 30% of households to 50% of households, and by when, something much more precise. So these kinds of, this kind of thinking, I think, leads right into the next thing that I want to talk about, which is action planning. So when we do plans, we want to do fairly detailed plans that specifically support program objectives. For instance, that delineate roles and responsibilities, the timelines, what are the resources that are going to be needed to execute the plan, both financial and non-financial, what communication strategies will the team be using to disseminate information out to the stakeholders or the community, what data sources or evaluation strategies are going to be used, and so forth. So again, here we're still like pretty high level in our thinking about, you know, what are some of the conversation pieces that we would want to have just at the beginning stages of starting on a program planning exercise. And these are some of the things that you would want to at least have a general conversation about with your team or other local people that are going to be involved with the work. What I want to do next is talk about a couple of different models to getting this done. And I'm going to land ultimately on the logical framework approach, which is the one which is the most commonly used by CDC, but also by different health ministries around the world. And it's the most familiar to a lot of people. And so, you know, you could stroll into any international non-government organization or government organization or local non-government organization, pretty much any country in the world, and ask what their logical framework is, and they would be able to tell you. So it's very common, but it's not the only one out there. And so I wanted to just at least briefly expose you all to three other ones. One is the RAND model getting to outcomes. And you can see in the schematic here that it has kind of a 10-step or a 10-part cycle that goes from identifying needs and resources and kind of walks you through some of the things that I just talked about over the past few minutes, and then has a kind of an iterative process that's defined in the middle between planning, delivering, and then evaluating and improving. And those, you know, circle back onto each other, because you should always go back and forth between planning and delivery across the timeline of your project, because inevitably, because of change, personnel change or circumstance change, maybe there's a natural catastrophe or an epidemic or whatever, you need oftentimes to do some new planning as you go along. So that has to be iterative. There are two other models that I teach about on campus here in one of my classes. And those are the pre-seed and proceed models. And these really came out of the social and behavioral sciences that influence public health thinking and a theory behind public health program planning in some settings. And I'm not going to walk through all of these different dot points, but the proceed model grew out of the, or the pre-seed model and proceed model are linked. The pre-seed model is an improvement upon the proceed model, and they're used in some settings as well, although less common. We're going to disseminate these slides afterwards, so if you feel like you've missed a dot point or a bullet along the way, don't worry. You can circle back to it in your own time later after our time together. So that brings me to logical framework, and I wanted to let you all know that this framework has a long history, and that history actually is in the field that I started my remarks with this morning, having to do with international development, because it was developed initially in 1969 by people who worked at our bilateral development assistance agency, U.S. Agency for International Development, and the agency rolled it out in the couple of years after that in 30 countries. So it has long history. Today, in addition to AID, it's also, you know, as I said before, broadly used in this country. It's the main program planning and evaluation framework used by CDC. And it's also internationally used, like I was saying. So the crucial piece of it is the log frame matrix, which is a 4x4 project table, which I'm going to show you examples of. And one of the things that a logical framework makes us do is scrutinize our assumptions going into program planning and asking us to revisit our assumptions. So assumptions are external influences on the program. Those external influences can be positive or they can be negative. We want to scrutinize our assumptions, and we also want to make sure that our programs don't have what's called a killer assumption. In other words, an assumption that will kill the program if invalid. So for instance, if you're developing a program in a setting where the political situation is unstable, but your program depends upon political stability, that is a killer assumption. You can't assume you can't design a program based on the idea that the political environment will remain stable when you're working in, say, a war-torn country or in a setting where you cannot rely upon a particular administration, et cetera. So we see in our state and all states, as the governor's office kind of cycles between the parties, that new people are appointed into positions, and those new people have new agendas and new emphases, and that's totally normal and totally expectable. So it wouldn't be a great idea, for instance, to plan a program in November of an election year, which has the assumption that all of the same people are going to stay in place and all of the same program emphases and flows of money are going to stay in place. That would be a killer assumption. And so that's just, a couple of examples of that. Okay, what are the main features of the log frame approach? The first I've already talked about in here, that stakeholder involvement. The second is that it takes a needs-based approach. So it looks at what needs in communities are and focuses on addressing them. It has a very logical framework. It has a very logical way of thinking about program activities and their linkages to the problems that they're supposed to be resolving or addressing. So another way of thinking about that is that the approach is a series of if-then statements, and I'll give you some concrete examples in a moment. It gives us a framework for looking at relevance, feasibility, and sustainability. And if you remember the website I took you to a few minutes ago, on the CDC website, one of the first things that you would have seen was a little schematic that had some features of program planning and evaluation, and relevance, feasibility, and sustainability do appear in those. And that is a reflection of the CDC's commitment to this, this way of doing program planning evaluation. Results oriented, not feesults oriented, sorry, typo there, not activity driven. So a lot of program planning and evaluation tends to be focused on the widgets or the little nuts and bolts of a project happening. Like, for instance, a lot of the work that I do in Nepal is focused on the water, sanitation, and hygiene sector. And so a really common way of evaluating of activity-driven evaluations of that sector is simply counting things like how many trainings were delivered, or how many latrines were built, or how many tap stands were functioning and delivering water. But that's an activities-focused evaluation. So the activity of building latrines is evaluated. A log frame approach asks us to take a 10,000-foot view. In addition to how many of those things were built, how has the impact, or what impact has that had on the health outcomes that you're trying to move the dial on? Has diarrheal disease changed at all? Or other smaller or more focused goals, like how has hand washing changed as a result of having tap stands installed, et cetera. So there are different levels that you can focus your program evaluation on, and a log frame approach takes a results orientation, not solely an activity orientation. So it logically sets up the objectives that you've identified and describes their causal relationships with the outcomes that you're aiming for. And then it can show us if objectives have been achieved by the appropriate selection of indicators, which come in at the evaluation stage. And last, it describes external factors that influence the project's success, like I was describing before, those assumptions. Now, when we talk about the matrix, like I said before, that's one of the most important, it's like the centerpiece of a log frame approach. It boils everything down into one single 4x4 matrix and really helps other people who are trying to learn what it is that you're doing in your program. So the matrix is used to present information about your objectives, your outputs, and your activities systematically and logically. And it contains 16 cells organized into 4 columns and 4 rows. So this is what it looks like. So you have on the left column, you have goals, the project purpose, the outputs, and the inputs. And we tend to read these matrices from the bottom up. So you start with your inputs, your inputs lead into your outputs. Your outputs affect your project purpose, and the purpose of the project affects your ultimate goal. Across the columns, then we have first your objectively verifiable indicators, your means of verification. In other words, how are you going to verify those indicators? And then your critical assumptions. So here are some if-then statements that help explain. So the idea is that if you put these inputs in, like say for instance, staff time or trainings held in the community or X number of vaccines or whatever, and your critical assumptions are met. In other words, your staff time will be used wisely, your members of the community will come to the training, there will be appropriate and enthusiastic uptake of your vaccine. Those are your assumptions. Then your outputs will flow. You were able to deliver X number of vaccines. You were able to train this many people, and you were able to use your staff time doing X, Y, Z. So what I love about the matrix is that if you think about these arrows each time as you go through the chart, it really concretely helps you identify, like, what am I doing? Why do I think it's going to work? And how do I think it's going to work? And I find that very reassuring and comforting. Of course, it's not waterproof, but it gives us somewhere to start, and it forces us to think things through. And it seems like so kind of simple when you put it on the slide like this, but I can't tell you how many times I've been working with different development organizations, different kinds, where they just missed a step in their thinking. They didn't use log frame approach, and they just kind of missed a step, and things went sideways, or they ended up spending all their time doing something that didn't end up being advancing the work toward, moving the dial on the health indicator or whatever.